Neurology quiz number 31. Discuss the clinical features, diagnosis and treatment of neuroborreliosis. Neuroborreliosis refers to the neurological manifestations of Lyme disease. Lyme disease is named after Lyme, Connecticut, where it was first identified. It is due to infection with the spirochete of the genus Borrelia, which is acquired from the bite of an infected Ixodes tick. In North America, the disease is caused by Borrelia burgdorferi and is most prevalent in the northeastern states. Borrelia burgdorferi is maintained at high levels in animals such as field mice and white-tailed deer. More than 20,000 cases occur each year, and it peaks during the summer months. Borrelia is transmitted to humans by the bite of an infected tick or the deer tick, and transmission requires 24 to 48 hours of tick attachment. Infection is mostly caused by nymphs, as they are very small and difficult to see, while adult ticks are more easily seen and removed. Spirochetes multiply in the tick GIT and migrate to the salivary glands and are then injected into the host. This is a slide showing the areas of high incidence in the US, many of the eastern states, and in the north, Minnesota and Wisconsin. This slide shows the small size of the nymph, which is why it is difficult to detect and remove. The disease can be classified into the following stages. Stage 1. The incubation period is 3 to 30 days, after which a characteristic enlarging target-like lesion known as erythema migrans is evident at the site of the tick bite. The target appearance is caused by central clearing as it enlarges. There may be associated flu-like symptoms such as fever, headache, myalgias, and arthralgias. The figure shows a typical lesion with a target-like appearance. Stage 2. After several weeks in untreated patients, hematogenous dissemination occurs and neurological and cardiac involvement may be seen. The most common neurological presentation in the United States is lower motor neuron facial palsy, which can be unilateral or bilateral. It is mistaken for Bell's palsy, but bilateral involvement, systemic symptoms, headache, history of tick bite, or a skin lesion suggests Lyme disease. 1/3 of patients have CSF pleocytosis. Less commonly, cranial nerves 3, 4, 6, and 8 may be involved. Meningitis can occur, which can be acute or subacute, and is characterized by headache, photosensitivity, neck stiffness, and fever. CSF shows lymphocytic pleocytosis, high protein and normal glucose. Raised intracranial pressure and papilledema may occur, but is more common in children. Lyme reticuloneuritis presents with pain in the distribution of the affected root. Pain is often severe, deep muscular, and not relieved by common analgesics. It is confused with structural root disease. Acute mononeuropathies, mononeuropathy multiplex, and an AIDP-like presentation may be seen. Subacute painful meningoradiculitis is also called Banmarth syndrome and is the most common manifestation in Europe. The most common features of cardiac involvement are fluctuating AV block. Stage 3. In this stage, patients develop monoarticular or oligoarticular arthritis of large joints, especially the knees. A skin lesion labeled acrodermatitis chronica atropicans is common in Europe during this stage. Encephalitis with disturbance of memory and cognition, as well as myelitis and encephalomyelitis have been reported. MRI brain can reveal subcortical white matter hyperintensities. Rarely, cerebral vasculitis may occur. Neuropathies can occur at this stage and include mononeuropathy, mononeuropathy multiplex, or polyneuropathy. This slide shows a FLAIR MRI in a patient with Lyme disease with subcortical white matter hyperintensities. Diagnosis is established by serological testing. The CDC recommends a two-step procedure. Initially, an ELISA test for antibodies to Borrelia burgdorferi is obtained. If negative, patient does not have Lyme disease. If positive, Western blot testing for IgM and IgG antibodies is performed. IgM antibodies are significant only with illness of 4 weeks or less in duration, and beyond this point are likely to represent non-specific cross-reactivity. IgG antibodies are all positive in all patients except in the earliest stage, and in this situation CSF examination may be needed to make the diagnosis. Patients with ongoing neuroborreliosis have CSF pleocytosis. As antibodies can be passively transferred from serum to CSF, CSF to serum antibody index is used to detect intrathecal production of antibodies. This index is positive if it is greater than 1.3 to 1.5. Treatment guidelines are as follows. Lyme, cranial neuropathy, meningitis, and radiculoneuropathy can be treated with oral doxycycline or IV ceftriaxone or IV cefotaxime or IV penicillin G. For Lyme encephalitis, myelitis, and encephalomyelitis, where parenchymal involvement has occurred, IV antibiotics are preferred. The doses are as follows for the various agents.